Dr. Chinmay Shah and all other co-panelists and Dr. Ravi Wankhedkar. Ravi Saab, if you remember, I was the conference chairman for the Amaravati conference in 2018, telemedicine conference. Yeah, we'll proceed. As Dr. Ravi Wankhedkar has told, the first portion talks about the doctors and do's and don'ts, mostly don'ts. And before that, I will give a clarification. I am not a doctor, but I am a doctorate. I am more particularly focusing from the telemedicine point of view. To give the generic opinion on the first segment of the doctor's things, really, I also felt that whether all these rules are they implementable, because they are telling any conference, workshop, or any session sponsored or co-sponsored by any pharmaceutical company also should not be allowed. That should not be, the RMP should not participate. Is it practical? We should not be generally prescribing or pushing for one particular drug. That is understood. But that applying across the board and saying that no conference, workshop, or etc. should be attended by doctors, which is sponsored by a pharmaceutical industry. I don't know how far that is practical. And I don't know, unless Dr. Ravi Wankhedkar told now, what are the other rules already existing for doctors. But generally, I felt that some of the rules are impractical. Though they are good ideally, they are impractical. But only one point I wish to differ from Dr. Wankhedkar is, it is not with a suspicion that a doctor will do bad or doctor will do mistakes. I felt that it is to protect the doctor himself as well as the patient, because as long as things go smooth and well in 99% of the cases, there is no issue. No patient will come back to doctor and say, okay, Dr. Saab, I am okay now, thank you very much. But only in 1% or less than 1% of the cases where there is any issue or further aggravation or any unfortunate event, there will be a case and then looking for a tracing of the diagnostics, tracing of the consultations, etc. So I saw that from that angle, that though it is looking like a laborious and cumbersome process, better to follow and stick to these things. Okay. Having given that introduction on the first segment, general medical portion, I will share a screen for the telemedicine portion. Can I go ahead?
Yes, sir. Yes, sir. Definitely.
Yeah. Ravikant? Ravikant? No, sorry, try. 1 minute, sir. How many of you desktop sir, how many of you have gone through the first telemedicine guidelines of 2020?
Sir, I think not more than 50% have just gone it, because those who have used, and I think directly used by only 15 to 20% people during COVID. Other is used as a third party. So I think not more than 20% people have gone through the telemedicine guideline till date.
Yeah, if you see basically, now screen share, desktop file. I am at Hyderabad and using my son-in-law's computer. It is a Apple computer, opposite of the world. Yeah. So to save the time, what happens is in the screen. NMC screenshot. Sir, what happened is actually, if we have seen the 2020 guidelines, there are no major changes except they have elaborated some things. And then they have PDF document, NMC. They have elaborated some places and one or two things like ethical aspects. They have, yeah, are you able to see the document, sir?
Yes, sir. Yes, sir. Yes, sir.
Yeah. So I am highlighting.
First page. Right now, we are able to see the first page.
We are on the first page, right?
No, sir, not moving, sir.
Not moving, yeah. So the ethical aspects and complaining aspects. Ethical aspects and complaining aspect is added. What they said is at one place, in case of any malpractice or any problem or irregularity in case of a teleconsultation, go down. How to? One page better. In case of that, the complaint has to be given in the state council where the doctor has initially registered. That is a new addition. Okay, sir.
Yes, sir. Yes, sir. Yes, sir. Now it is moving.
Yeah. And in another case, what they said is if the doctor is giving a consultation when he is on tour, suppose from doctor from Mumbai, when he is on tour to Delhi and he gives the consultation, and in case of any complaint or irregularity, the complaint should be registered in the state council from where the doctor has given the consultation. This we felt in the previous discussion in the Karnataka chapter also is impractical, because there is no place where you will capture where from the doctor is giving consultation. You will know who is the doctor, what are his credentials. So he may be moving from place to place, and also there is no real authority for the other state councils or state authorities to look into that. So better we thought that the complaint in case required should be given to the state from where he is registered. Do you agree? Hello?
Yes, sir. Yes, sir. Yes, sir.
Yeah, so that it is for a traceability. Like in case of police stations or anything, they will say that you have to give where it happened or where your place of residence or some anchor point is there. By God's grace, such a situation should not come. And the generic drugs and prescription guidelines and all we have seen. Responsibility of RMP also we have seen. I will go to the telemedicine chapter. Major problem comes in the issue of the consent form. Consent form in case of the telemedicine consultation, because in the normal cases it is easy. We will take the signature of the patient or his attendant. But in case of the telemedicine, what they said is you have to take the consent in any one of the forms, either in text form or video form or a voice where the language is comfortable to the patient. He can read aloud the consent and the doctor has to read. Doctor has to record and maintain that as his medical record. Or he can sign a form and then send a scan copy. Sorry, I'm taking long time. Yeah, this is the certificates. At least now they have added more forms of certificates and clarity has come. Yeah, here. Sir, the informed consent and explicit consent and implied consent, two words are used, and ethical issues in telemedicine is one new thing. I have highlighted in yellow, and then telemedicine triage and COVID care. This was not there. Though the telemedicine practice guidelines were issued at the time of COVID, this particular issue was not mentioned. And more specifically, the new thing is the special responsibilities of NMC and the sample patient information sheet and the sample consent form are given. What they said is, okay, these guidelines are useful, etc., etc. And the NMC considers the telemedicine as not as a supplement or a replacement, but an extension of the normal in-person care. So they say that in general, all the rules, regulations, ethics and moralities and everything, whatever is applicable for doctors in person consultation are applicable here also. But more care is to be taken because of the tele portion, where the data record and the data maintenance and the secrecy, where the ease of the problem with the ease with the digital is anybody can connect to anybody. But the difficulty is any data can go to anybody also so easily or equally easily. So the care should be taken there. So they said that these guidelines should be used in conjunction with other national laws, rules, regulations, clinical standards, protocols, policies, and procedures. They are an extension to that. And an RMP, in case of any complaint, this is what I mentioned already. In case of any complaints of a misconduct, the complaint will be lodged in the State Medical Council of the state where the RMP is located at the time of providing teleconsultation. This we thought in the Karnataka discussion, here also I need your input, is slightly impractical. Then all RMPs who wish to practice telemedicine should be made familiar with these guidelines as well as with the processes and limitations of telemedicine practice, and they need to undergo CPD training in telemedicine practice as per the ethics guidelines of NMC 2022. Earlier, what they said is within 36 months from the regulation of from the release of these telemedicine practice guidelines, all these doctors have to go through and qualify in an orientation course on the telemedicine. And for that, they have formed a committee under the chairmanship of NIMHANS to form the curriculum. And all the doctors have to go through that curriculum and get them qualified. Now they have replaced it with a CPD training defined under the NMC 2020. So that this is basically to understand what are the do's and don'ts in a telemedicine, in a in-person versus telemedicine consultation, and what are the extra cautions he has to take. These are all the normal things which are old only, where the telemedicine can be used. Patient to RMP, a caregiver to RMP, RMP to RMP, or a health worker to RMP like a ASHA worker or anybody. So they are same things only. And here they have told the limitations and the advantages of the different modes. If it is a video, if it is an audio, or if it is only pure text based. I'm not getting into these details. They have given these details, but here in the limitations of the text based, what they added new is both the RMP and the patient cannot establish each other's identities with surety. Because in case of any teleconsultation, what they say is the doctor and the patient should introduce each other. They should know each other and feel comfortable to go ahead with the teleconsultation. Then only the teleconsultation should start. And also beginning of the consultation itself, the age of the patient, if it is essential, the patient has to establish his identity and age also through a proper recognized and registered age proof. And also the doctor has to introduce his name, certification, qualification, that unique ID and the state registration, etc. Here, some of the people have felt that how can every time the doctor introduce? In case of any video call or any audio call or in any multimedia call, it is not a problem. They can introduce. But only in a text-based call, this becomes a difficulty. That is a kind of a limitation where the RMP and the patient establishing their identity. Because here also again, as long as things go smooth, nobody bothers who has given consultation and he will be happy. In case of any misfortune event, they will be looking for who is the culprit and whom to be charged with. Then other thing is, they say, anyway, this is new only, old only. How to see where are the telemedicine consultations possible? They have to be decided based on 7 parameters like what is the context and whether you can identify the RMP and the patient. That is introduction of each to the other. Mode of communication suitable, and whether the consent form is given, and type of consultation, patient evaluation. It is up to the doctor's right to see whether he is comfortable to give a consultation, or I mean teleconsultation, to the patient even in the given context with the given technology and for that particular disease. Otherwise, he can simply say that, sorry, I cannot proceed with this call, or I cannot handle this through the teleconsultation. You go to the nearest doctor. At the same time, the doctor cannot insist a patient to come in person when the patient is comfortable with the teleconsultation. So both the cases he cannot insist. He should be available, and on mutual consent, they can go ahead with the teleconsultation. Then here no two patients or cases or medical conditions are the same. So the complexity of the patient's health condition is important, and the doctor has to understand the differences between the cases and decide for himself. The full right is given there, as well as with the patient to go ahead or not. Then this is all the consultations only. And the teleconsultation, earlier they said that the doctor RMP or RMP to RMP, patient to RMP, etc. Teleconsultation can happen as long as they are comfortable. But here they have made it explicitly clear that that should happen in a language that the patient is comfortable for understanding and comprehending the advices. And RMP should begin the consultation by introducing themselves. This I have told already. And for specialty consultation, the RMPs or specialists may choose to discuss and disclose their specialty qualification, MD, MS, etc., equivalent recognized qualifications. Here, the case of individual doctors is one thing. Okay, he may show one slide of his name, identity, qualification, specialty. But in case of an aggregators or the doctors of empaneled hospital, empaneled in a hospital, probably the hospital can do the homework and then do the display of the doctor's qualifications and criteria and degrees, etc. The RMP should verify and confirm that the patient's identity by name, age, address, email ID, phone number, registered Aadhaar ID or voter ID or any other identification. This we have discussed. Age may not matter every time, but in particular diseases and particular prescriptions, age also may be important. So the doctor can insist an age proof from the patient whenever he feels required. And the RMP should consider their strengths in the mode of communication. The RMP should consider the strengths, limitations, and appropriateness as detailed in the previous section we have seen. Before utilizing them for a consultation, invariably the combination of the above mode occurs to complete a telemedicine consultation. So definitely it is up to the doctor whether he is comfortable with the mode of consultation. Suppose if it is a very complicated case and he is simply using a normal phone, not a smartphone, and he wants to get a consultation only on a voice call. So the doctor can judge himself whether it is worth going ahead or asking him to go ahead to a nearest hospital, not to get himself into the risk. Then patient consent, again they said that it is of two types: implied consent and explicit consent. If the patient himself has initiated or solicited the telemedicine call, then it is deemed as a implied consent. Then there is no problem of recording the consent. But if the doctor or the caseworker or the healthcare worker, if they initiate the consultation, then an implied consent, explicit consent is required. Here only they said that consent can be in a graphics, text, audio, video, podcast, or any interactive website, or what we have discussed in the Karnataka chapter meeting again is, in the initial form itself, they can give a consent for the telemedicine also. When they are providing their initial details and patient information, they can tick mark simply saying that, yes, I consent myself to be consulted by a teleconsultation. So this is the thing. And it is the here explicit consent is made as a responsibility of the RMP to take the patient's signature or thumb impression, etc. Here the care must be taken. Then for follow-up consultations, earlier again, for those who have not read the telemedicine consultation practice guidelines earlier, what they said is, if a teleconsultation can be done if a patient has had in-person consultations in the past 6 months for the same disease. If he is coming for a new disease or for a new symptoms, then it should not be called as a teleconsultation, or he cannot take up a teleconsultation. And in case of once he is on board on the online consultation, he can be continued with the teleconsultation. But here that continuation of the further follow-ups is not there explicitly. So we have felt that that should be added here to say that once a patient is seen by the doctor in the last 6 months, he can go on board on the online consultation. And after that, further follow-ups should be deemed as agreed or consented for the teleconsultations. Am I clear, sir?
Yes, sir. Yes, sir. Very clear, sir. Very clear.
Yeah. And if a patient is not able to obtain an appointment with the same RMP for a follow-up consultation, owing to operational reasons of the digital platform being used, consultation with another RMP will be considered as a follow-up consultation. Only if the second RMP is comfortable in comprehending the patient's medical conditions after having been provided the adequate information, that is details of the condition, previous case history, etc. This is again similar to like our physical in-person consultation also. Whenever we are going to another new doctor, why do we go? Only when the doctor is not available on that day, or he is transferred or no longer available in that hospital. And the second doctor will naturally accept the case to be seen only when he is comfortable and he is provided with the previous case history and case file. So same case applies here. In the follow-up also, another RMP can see a teleconsultation provided he has got the previous information. But what happens is, the guidelines generally say they don't prescribe or make it compulsory for any particular hardware or software. But what happens is, if it is in a off and on consultations on a WhatsApp or some other media, then the previous record, previous history recording and maintaining is difficult. So though it is not mandatory, at least for the doctors and more specifically for the aggregators and the big hospitals where they are providing the teleconsultations, they are advised. Again, they are advised is the word, not prescribed. They are advised to use some system, some software or the other, some application or the other, where they can record the history of the patient, what was the previous prescription, what were the previous modalities and symptoms, and so that anybody can take over. This is again similar to anything. But if it is just a video call sometime between friends or a family doctor, that is fine. But if the patient goes to the same doctor on a WhatsApp call after 3 months without any record, that is a difficult case. And also the guidelines say, even if the doctor is being seen or even if the patient is being seen by the same doctor for the same case within 6 months also, if the doctor cannot comprehend or remember his previous history, or he doesn't want to give a consultation on the teleconsultation, the doctor has got the right to reject that mode, because he sees some complication or he is incapable or whatever is the reason, or he is unwilling, whatever is the reason, they have given the right for the doctor to reject the request for a teleconsultation. Then the other one is in the patient evaluation, exchange of information. So the patient information, like what we said is the doctor has to get the patient's age, name, and other information. And it is up to the RMP to get the data and get himself satisfied. But here also what they said is the technology based tools and the technology provider has to take the responsibility for providing the doctor's full information to the patient in the case of the other way. But here what they mean is not exactly, suppose if a doctor and patient are doing a consultation on a WhatsApp, definitely WhatsApp is not going to do that. So again, we have to explicitly make it clear or ask them to make it clear that this is applicable in case where the doctor or the aggregators or the hospitals are providing. So they can do the homework and provide the relevant information and background information and qualifications of the doctor. Otherwise, it is not possible. So it is the responsibility of the doctor. Definitely the technology provider cannot take that onus. Is that clear, sir? Is that agreed?
Yes, sir. Yes, sir.
Similar, exactly like WhatsApp. In WhatsApp, whatever rumors or nonsense we spread, how in the normal social media, how he is responsible? He is only a medium. Similarly, here making him accountable for informing the doctor's data to the patient is not practical. So what we thought is it should be asked and requested to be amended as the aggregator or the hospital which is owning the platform should take that responsibility. Then the health education, doctors not only for disease management, what they say is the doctors should also make the use of this platform and teleconsultations to provide advices on immunization, exercise, personal and household hygiene practices, etc. That is all the preventive care, not only the disease management. And prescribing the drugs, here also, if you have seen the earlier things, now they have slightly elaborated. Otherwise also there are 3 drug categories called category O, that is open, category A, list O. List O, that is generally available across the table or over the counter without the prescriptions. And then other one is the list A. These are the drugs which can be prescribed during the first consultation only in cases of video consultation. And if they are being repeated, prescribed for a refill or in cases of a follow-up consultation. So this is one other list A is given. And then here the change is they are prescribed again or repeated in a follow-up teleconsultation. And in these situations, the patient has been seen, investigated, and the diagnosis has been established by the RMP. So then only he can prescribe a refilling. Then list B is a list of drugs that RMPs may prescribe for patients during follow-up consultations as add-on drugs, in addition to those drugs that were prescribed during an earlier in-person consultation for the same medical condition. Here again, the not is put in capitals, not a new drug for a different medical condition or diseases. So it is only an add-on for the previous consultation. For example, to better control the hypertension, the RMP may prescribe an add-on dietic to a patient on an anti-hypertensive drug prescribed earlier. So like that, it is only a simple add-on, but not a substitute or a replacement or altogether a new drug. Then in that case, the doctor has to take care. Then again, the third one is the list of prohibited drugs, which are psychotropic and narcotic drugs, which otherwise are also very prohibited in nature. So the Schedule X drugs, they have given the Schedule X drugs and they said that they will be updating from time to time. So except two things, clobazam and clonazepam and what is it? Okay, whatever. The 3, except these 3 medicines, none of the other Schedule X drugs can be given over a teleconsultation. So this applies equally in the in-person also, I believe. Then the issue issuing a prescription and transmission. What they said is the doctor has to transmit the prescription ideally in a signed form with his name, signature, unique ID, registered medical ID, and the state registration number, etc., etc. And the prescription should be ideally in capital letters. These are all normal things only, I think. But if that is not possible, at least he should make available a recorded version of this prescription and make it available through some other media where the patient can access it. Or in certain cases, the RMP may directly transmit the prescription to the medical shop. So in those cases, the patient has been provided an option. The doctor cannot say that I have transmitted your prescription to my attached medical shop. You have to go and take medicines only, there only. That condition doctor cannot put. So there they have given the liberty for the patient to see whether they can go to that shop provided or prescribed by the doctor, or they can go to some other pharmacist. RMP shall provide a clear photograph, scanned or digital copy. This I have told already. And then prescription can be conveyed to patients who do not have a smartphone by using an online web application that can be accessed from a mobile browser. So it is the responsibility of the doctor to keep it online, and the patient or his attendant or his pharmacy person can download it and then go ahead with that. Then these are the things, these are the advices and list of prescriptions or the drugs which can be given. Suppose the O category is open category. So whatever is the mode of connection and communication or consultation, and whatever may be the nature of consultation, they can be given. And A, the list A drugs can be given only for a video consultation and first consultation or follow-up consultation in continuation of the previous call, like we have discussed earlier. Then list B, any mode of communication is okay, any consultation is okay, but it can be given only for follow-up. List B is what we have seen is the additive medicines. And prohibited things is the list X. Whatever is the mode of consultation, except that 3 drugs which are exempted at this moment, it cannot be prescribed, and they are under the banned list or the prohibited list. So this is this I am not reading. So they have to take care in that. Then this is the new detailed chapter compared to 2020. That is the ethical issues in telemedicine. So in general, they say that anybody, any RMP following a teleconsultation is deemed as providing an in-person consultation. So are the ethical, moral and standard procedures and rules should apply here also. But here the physicians must respect the following ethical guidelines when prescribing telemedicine. That is what the RMP patient relation should be established. That's what we discussed already. They have to know each other and feel comfortable with the mode, need and the convenience of the teleconsultation. And the RMP patient relationship must be based on mutual trust and respect, and it cannot be an anonymous. A patient cannot be consulted or cannot be advised by a doctor being himself anonymous. And the RMP must aim to ensure that the patient confidentiality, privacy and data integrity are not compromised. This applies equally in the normal case also, as we have seen. But here, this is a double-edged sword. The digital technology is useful on one side, but at the same time, it is dangerous that it may be misused on the other side. So here the doctor or the establishment should take care that the patient information, particularly the privacy and the confidentiality of the patient and the medical information, is preserved. But the guidelines do not say particular server, particular operating system or particular technology. It is technology independent. But the doctor and the establishment should take care that all the care is taken to maintain the confidentiality and the secrecy of the information. Then autonomy and privacy of the RMP. At the same time, autonomy and privacy of the RMP is also protected. The RMP should not participate in telemedicine if it violates the legal or ethical framework of professional behavior or any rules or regulations under the NMC Act. So he can think that this is not suitable case. He can reject the teleconsultation request. Telemedicine can potentially infringe on the free time of the RMPs if there is round-the-clock virtual availability. The RMP needs to inform patients about their availability and recommended alternative or emergency services if they are inaccessible. So this is fair and good. But the dichotomy is, like Mr. Dr. Ravi Vanketkar told, the doctors cannot advertise themselves that they are available for teleconsultations. They say they can inform that they are available. The line of difference between these two is very thin, but they cannot advertise. When a hospital or when somebody can say that I have got 4 pediatricians, 8 ophthalmologists, and so many cardiacs, and they can advertise about themselves, why the doctor cannot himself say that yes, I am a doctor in neurology, neuropathy, or etc., and I am available for teleconsultations during this time. So that line is very thin line. So that should be defined very clearly. Then responsibilities of the RMP. This we have seen again. All the records and everything should be maintained well, and they should respect the patient's care, etc., etc. And the quality of care is to be maintained. This is similar to the normal things. And it is the responsibility of the RMP and/or the telemedicine service provider to be cognizant of the current data protection and privacy laws. So the digital data laws and the privacy laws, they keep changing. So they themselves should be aware of those things and they should comply with the concurrent laws. RMP shall protect the patient's confidentiality as a normal in all normal conditions, as if it is a in-person consultation. Maintain digital trial or documentation of consultation. This I said, up to 3 years, the consultation records have to be maintained. In the physical world, what is the period of physical files to be maintained, sir?
It is already 3 years. There also it is 3 years.
Okay. So here also they said that the digital data should be maintained in a proper server with sufficient coding and encoding and secrecy for 3 years. And the new thing is, if audio and/or video recording of the consultation is required, the RMP must take explicit informed consent from the patient. Similarly, if the patient and/or the family members want to record the audio and/or video of the consultation, they should take consent from the RMP. Those recording without consent will not be accepted as evidence. So in case of any medical legal cases, if somebody wants to produce, this is self-evident. If somebody wants to produce, they should have a recording of audio or video which is already prior consented by the patient or the doctor. So better to take this, because we don't know when the situation will come. So better to take the consent, explicit consent of the doctor and the patient in all the cases, or to be on a safer side. The other thing is framework for telemedicine and all this we have seen. Patient can talk to doctor, doctor to doctor, peer to peer, or health worker to doctor. And another thing is emergency situations they have added. And quick assessment based on the input received, the patient condition is quickly assessed by the RMP before deciding to take up the teleconsultation request, yes or no. And then the teleconsultation process is described here, which I'm not telling. That is start of the things. Then assessment, making an establishment of the identity of each to the other, etc., etc. And those details for all the 4 categories are given. Teleconsultation between doctor to doctor, doctor to other peers, and in emergency situations. Here, emergency situations, you have to remember, patients may call any RMP during a medical emergency and insist on teleconsultation. However, the RMP may not reply or give any specific advice In all emergency cases, the patient must be advised for in-person interaction with the registered medical practitioner or specialist at the earliest possible. If that is not possible, they say that at least doctor on teleconsultation should give them the first aid and other minimum things which they have to do in the golden hour or before going up to the doctor. Then this is the guidelines for the RMPs and technology platforms. This I said. Again, RMP shall not participate in telemedicine platforms that provides ratings by a patient or others, including reviews, advertisements, and promotions of RMPs by any means. That is manipulation of the algorithm or search engines, etc. Advertising of RMPs is not allowed by anybody under any pretext. I don't really know what is this dichotomy. Because though it is not as a commercial thing, his availability should be available, made available or informed to the patients, right? So the thin line between advertising and information is to be maintained. And technology platforms, this I said earlier, we have discussed. The technology platforms are obliged to ensure the consumers that they are provided the care and the information. That is not possible like we have seen. So here, this we wanted to say that it should become the responsibility of the hospital or the aggregators to take the responsibility of maintaining, collecting, maintaining and sharing the patient data to doctor and doctor data to the patient. Then again, what they say is, here in the case of technology, you may use any artificial intelligence or any algorithms or any neural networks or anything for your background work. But finally, the decision or the prescription should not be by a machine or a machine generated prescription. So they say that you take whatever inputs you want from XYZ. Ultimately, the prescription has to go from the medically qualified doctor in the light of those informations. And in case of any specific technology platform, in case any technology platform is found to violate these guidelines or any applicable existing laws applicable to them, the EMRB, that is the Ethics and Morals Board, or NMC may designate the technology platform as blacklisted, and no RMP may then use that platform to provide telemedicine. Here again, the previous discussion applies. Suppose in WhatsApp, for some case happens, can they ban the total WhatsApp? It should be modified as that hospital or that aggregator who has not taken care. And the good thing is, earlier they have explained these things, but this time they have put the graphical representation for all the 4 consultations between doctor to patient, sorry, doctor to doctor and doctor to caregiver and doctor to the health worker. And also they have told what do you mean by a first consult and how do you establish the contact between the patient and the doctor. These all 4 cases were well explained. I'm not going to say this. These are all the health worker and the registered medical practitioners, etc. And the new thing we have seen is the drug list. They have elaborated and they have told what are all the drugs in the list O, list A, list B, and the prohibited drugs, that is the X category. So that finishes the changes in the telemedicine practice guidelines from 2020 to 2022. So in summary, I can say that they have elaborated some of the points which were mentioned at a macro level earlier, but they have not altogether brought great changes other than introducing the complaint portion and the medical, moral and ethical aspects of the RMPs and the responsibility of the EMRB or the NMC. So I have done with my presentation.
Thank you very much, sir. And now I think you have covered, sir, almost all the questions. So now I request Dr. Pragnesh, sir, from Management Medicos to please give a vote of thanks and any other information or summarize the session. Over to you, Dr. Pragnesh, sir.
Thank you, Dr.
Sir, before Pragnesh sir, before concluding, I request Dr. Chinmay to summarize and give the suggestions tomorrow.
Yes, sir.
As an outcome of
Sure,
this,
sir. Sure, sir.
As an outcome of this one.
Sure, sir.
And Dr. Vankadkar also, he has made so many open remarks, but instead of telling what is bad, we should also tell what is good or what is required.
Okay, sir. Okay, sir.